Well, thank you so much for being here for one of the most pivotal lecture series that we have within our grand rounds, which we fondly call Cougar. It is the Columbia University Epidemiology Grand Rounds. And this is the Berkman Lecture. And so, what I'd like to do is first give you a little bit of background about Dr. Berkman and also the gratitude that we feel for his friends and his family for being here. Thank you so much. And then I'm going to introduce our illustrious speaker, Dr. Ojikutu, and then I'm going to hand it over to her. So we're going to hold all questions towards the end, and we're going to ask for the in-person audience at the end to come to one of the mics to ask a question. And then we'll also be accepting questions from the online audience as well. So today we gather for our Cougar lectures, and it carries deep meaning for the Mailman School and the broader public health community. This lecture is in honor of Dr. Alan Berkman, whose legacy as a teacher, a scholar, a mentor, a friend, a physician, a relentless advocate, a husband, a father. He was about social justice. He was about community, and he continues to resonate within all of us. Dr. Berkman's journey into academia was anything but conventional. His unwavering commitment to healthcare as a human right took him to the front lines of some of the most significant social events of our time. Whether it was crossing government blockades to provide medical care to Native American activists at Wounded Knee, or treating inmates wounded during the Attica uprising, Dr. Berkman never hesitated to take action where it was needed most. His dedication to healing extended beyond any boundary, even landing him in prison when he refused to cooperate with federal authorities after treating an injured activist. But his incarceration didn't silence him. It doesn't really silence advocates in general, but instead, it fueled him. And it fueled his advocacy for the humane treatment of prisoners, pushing for improved health care within the prison system. Upon his release, Dr. Berkman redirected his focus towards the burgeoning AIDS epidemic, becoming the medical director of one of the first skilled nursing facilities for HIV patients. Now, this was located in the Bronx, where the crisis was hitting the hardest. Now, later, as a member of our faculty here at Mailman, he played an instrumental role in advocating for global access to HIV treatment, cementing his status as a champion for the most marginalized in our society. And as Jamila Headley, a renowned AIDS activist, once said, Alan's life was a testament to action. Action born out of a deep rooted commitment to justice. He didn't just care, he consistently showed up, invested his energy, intellect, and passion in making the world more just for everyone. So we are grateful to the Berkman family today for their continued friendship and their support, and the family members that also continue to support. And so, in that same vein, as we reflect on the incredible legacy of Dr. Berkman, it's clear that his life was rooted in a deep dedication to justice, equity, belonging, and improving health outcomes for many of those who are often left behind. From his early activism to his global works, he never lost sight of marginalized populations whose lives depend on access to not just equitable healthcare, but compassion. So, in that same spirit, we are honored today to welcome our keynote speaker who continues this important work of bridging the gaps in health equity, Dr. Bisola Ojikutu, the Public Health Commissioner of Boston. Dr. Ojikutu has devoted her career to addressing the health disparities that disproportionately impact underserved communities, particularly communities of color. If you've ever been to Boston, it's a huge job. As a seasoned infectious disease specialist, a public health advocate, and global health expert, she has been at the forefront of efforts to combat structural inequities in healthcare, from HIV/AIDS to our most current pandemic, which was COVID-19. Her leadership in Boston has been marked by relentless focus on promoting health equity, expanding access to care, dismantling systematic racism within public health institutions. And this is where racism has been called a public health crisis. And this is what she's tackling. Now, before stepping into this current role, she was a faculty member and still is at Harvard Medical School and an infectious disease physician at Massachusetts General Health. Her groundbreaking research and public health work has had a profound impact domestically and globally, including her leadership in global health. Much like Dr. Berkman, Dr. Ojikutu is dedicating her life to equity, belonging, inclusivity, and ensuring that the most vulnerable populations that are often forgotten in our society are taken care of, that they are instead prioritized in the fight for equitable health outcomes. We are incredibly fortunate today to have her deliver the Berkman Lecture. And I have no doubt that her insights will not only inspire us to continue with our own work in advancing justice, but it will be a great honor to Dr. Berkman's memory. Please join me in welcoming Dr. Bisola Ojikutu.
Hey, good afternoon, everyone. That was a really warm welcome, and thank you so much. I'm really, truly honored to be here, and thank you to Dr. Berkman's family for being here, for the support, just for being present. I also want to thank the leaders who put this together every year, certainly Dr. McDonald, Dr. Brannis, Dr. Morabia, who I have the pleasure of working with as an associate editor at the American Journal of Public Health. You know, I'm particularly humbled by being asked to be here because this lecture is dedicated to Dr. Berkman. You know, I, as an HIV doctor, know Dr. Berkman's history. I, trained at New York Presbyterian, the other campus, and certainly worked in New York City and know his work well in regards to HIV. And I also worked overseas, and I'll talk a little bit about that in South Africa when Health Gap was just, kind of coming into being. So I knew this and I know of him, but I had no idea that he was a revolutionary. I had no idea until Alfredo mentioned his review of the biography written on him, and I immediately ordered the book. And I was like, wow, I mean, this guy is huge, in terms of being a real true co-conspirator for social justice. Just impressive. And I think it's a story that needs to be told more widely, more broadly. People need to understand it and know that this is a path that you can take. You can be a true revolutionary. It's truly inspirational. So I'm really actually sorry that I never got to meet him in person, but again, honored to be here. I titled this lecture, Advancing Health Equity from Data to Collective Action, but I have to be honest. What I really want to talk about is this question that keeps me up at night. Why haven't we made more progress towards eliminating health inequities in Boston? Now, obviously, we're in New York City, but I'm going to talk about Boston, but I'll talk about it in relationship to what's happening here in New York City, because the reality is that Boston is small. It's a microcosm, and it's something that we could wrap our arms around. It's a resource-rich city. So why have we not made more progress, particularly given the fact that, we have a theoretically progressive administration right now, and we've had, progressive administrations in the past, but there's this history in Boston, a deep-seated history of structural racism, a deep-seated history of inequity, and it has persisted. And so what I'm going to do is I'm going to show you some data, and I think you probably know this data, but I'm going to show it to you because it really is telling about how deeply embedded the history of inequity is within our city. Then I'm going to talk about some of our strategies. And to be quite honest with you, I'm not talking about them to brag about them, to tell you a tale that's full of success. I'm telling you this because, again, this question keeps me up at night because I don't think we're always doing the right things. And I think we need to do things differently. So I'm going to share our challenges and I'm going to share some of our struggles. And hopefully we'll have some time to discuss and talk about how we can do things differently. But I think it's helpful, even though I really appreciated, the introduction, just to know a little bit more about how I got to local public health leadership, because I didn't wake up one day and say I was going to be a commissioner of public health. I actually had no idea, that I would be sitting in the position that I am right now. And I'll sort of tell you why. So after I finished internal medicine, primary care internal medicine residency down at the other campus, you know, PEPFAR had just rolled out. And I knew that I wanted to be an HIV doctor. I mean, I knew that. I was passionate about that. And I saw HIV, and I still see HIV as, sort of the end product of social ills, everything coming together and then arising as this huge epidemic. And so when PEPFAR rolled out, I was offered the opportunity to go to the most inequitable country in the world and start to help roll out some of the work that was being done and that was being imagined by folks at the time at Harvard Medical School. So I went to South Africa and I went to Durban. And while I was there, I have to say it was very challenging. Not only was it challenging because the HIV epidemic, which was huge, and antiretroviral therapy was just trickling in, but it was challenging because I'm a Black woman. And this was probably maybe 11 years post-apartheid. And as we know, when you have a history so deeply embedded, it's hard to get past that. So even walking into rooms and saying I'm leading and I have the answers and I want to teach you and let's learn about this, that was difficult for me. But I have to say that it really opened my eyes very broadly, very widely as to what's possible. I decided to actually stay in sub-Saharan Africa, and I ended up working, in probably 15 different countries over the course of a decade. I was working as a senior advisor and a clinical lead for a consulting company, but then I was also, still building an academic career. So what I did was I was basically looking at HIV treatment and how to expand access, how to get it out there to as many people as possible, even in the most difficult settings. So that's an aerial view of an internal displacement camp in Uganda. And we basically went in and tried to figure out, well, what are we going to do for people who are HIV positive? How are they going to continue to get treatment as they are transient? So key questions, important problems. And I think that what I was learning there is really about the bigger context. Why is it that things aren't moving along? Why is it that from a political standpoint, you had this big program, PEPFAR, that's wonderful, probably a gem, of a program, if we have to think about the best programs that we've had globally, as well as, thinking just, comparing it to domestic programs out there, but still wasn't working for all people in the most difficult settings. I was drawn back to the US after about a decade of doing this work, largely because we have social injustice and racial injustice right here in the US. And much of the work that I was doing was academic. So I have a research portfolio, but certainly I was working with governments, working on policies, helping to co-author our first Getting to Zero plan for the state. And it was really work that I enjoyed, I loved. It really put me in the center of things and really allowed me to really engage with communities, which I think was really important for me at the time and still is. But when I try to think of what's the through line for my career, what is the story I tell? What's my elevator speech? It really is about the fact that all of my work has really been focused on how do you overcome structural violence, how do you address structural racism, and how do you mitigate the impact on health, whether it be international or domestic. So if you look at structural violence, this is a term that we don't often use. I think, people maybe don't like it because it says violence, but what it is, we're talking about physical harm, certainly, but also mental, emotional harm. And that's what we mean by violence. And we're talking about the big picture. We're talking about the economic, political, legal, religious, and cultural structures, all of those things that stop people from reaching their full potential. And then its cousin, structural racism, a system of hierarchy, privilege, and power that excludes non-white individuals, perpetuates racial inequity, and leads to poor health outcomes. What does that do? What does it do in places like Durban? Okay, so you see that's Durban, inner city, sort of, I would say, the Tony area of Durban. You see it compared to a township. So you see that gross inequity and then how that turns into health outcomes and what it did in terms of the HIV epidemic. But you see the same thing in Boston. Okay, that's Boston. That's, the Victorians in Back Bay compared to an abandoned building in Roxbury. And we'll talk about this a little bit more, but it's that dichotomy that you see and that we should all open our eyes to as we look around the world and think about what is it that should be done differently. So I was very lucky, after doing a lot of work in HIV, as many of us did, transitioned to a lot of the work in COVID-19, really thinking about access, really thinking about structural racism, thinking about the disproportionate impact that COVID-19 has and continues to have on people of color. And what does that mean for our city? And it put me in different spaces. And I was lucky in that I was offered the opportunity to be Commissioner of Public Health. And at the time, it was the midst of, a surge, and just sort of jumped in head on. It was trial by fire. Let's get it done. Let's get everybody vaccinated. A lot of real intentional work to deal with an emergency. And quite honestly, as the emergency died, most people said, okay, so Bisola, you're going to move on, right? You have something else to do. But the reality is there are many, many things to do. And there are many, many emergencies to deal with. We just don't look at them as such, and maybe we should. So Mayor Wu was elected, the first female, first woman of color to be the mayor of Boston. Has been a great turn, a great change in terms of, what Boston looks like, how Boston appears, and how Boston actually behaves, I think. And she really wanted her cabinet to reflect the diversity of our city. And I think that's what she's done, and I'm very proud to be a part of it. But I think there's a lot more work than to change what people look like. We really have to change how we act, how we behave, and what it is we're intentionally thinking about doing in a city like Boston to change some of the dynamics that I've spoken about in terms of inequities. So as Commissioner of Public Health, I'm also Executive Director of the Boston Public Health Commission. And I just want to tell you a little bit about it. So the Boston Public Health Commission is the oldest health department in the country. Don't let anybody tell you differently. Not here in New York, not in Philadelphia. Don't let them tell you differently. It is the oldest health department of the country. Started in 1799, and this gentleman here, Paul Revere, was our first commissioner. Surprise, surprise! Not only did he do his ride, he was also apparently, really a Renaissance public health man. I mean, he really, sort of put inoculation on the map in Boston. He had his really, strong ideas about quarantine, about infection control. All things that made him the right person at the time to be the head of the public health department. But I think one of the things to say about our health department, which has been very important as I've looked at the history, is that we've really tried to be innovative over time. And oftentimes people look at government and think innovation really isn't, that's not the word you think of first, right? But there has been innovation here. And I think it's important to acknowledge that. One of the things that Boston did before anybody else was ban menthol cigarettes and ban blunt wraps. And other states have followed since, and very few have actually banned menthol cigarettes. But it was one of the things that we did sort of before other people. Before people were talking about racial justice, Boston was talking about racial justice and had a framework together. And isn't that interesting that that was Boston? Because if you think about it again, there's this history, there's this mythology. I call it mythology. It's a reality. I shouldn't call it mythology. That Boston has a legacy of racism. And I'm going to show you some of the history. But it's just this interesting dichotomy when you think about the things that were happening in public health and the things that, sort of characterize how we consider public health in Boston different from the larger context of Boston as a city. So in 2020, I'm going to talk a little bit more about this. Racism was declared a public health crisis in the wake of the tragic murder of George Floyd. And then in 2022, now I was in my position at that point, I said, you know what, we're looking at all this history, we're talking about all these things of inequity. What does our mission statement actually say? And at the time, it didn't say much. It was very standard, very basic, protect, promote, preserve the health and well-being of all Boston residents, especially those who are vulnerable. But I said, you know what, team, let's work on that. Let's say what it is we're really here to do. And so we changed our mission statement. We went through a pretty long process to make sure that everybody was on board. And we said, you know what? Our goal is to work in partnership with communities, because communities must lead. We must shift power to communities to protect and promote the health and well-being of all Boston residents, especially those impacted by racism and systemic inequities. Now, personally, I think we're all impacted by racism and systemic inequities, but this is the way the team wanted to word it, and that's what we went with. So sometimes people will say, but a mission statement, so that's just words. But no, this really embodies what we're trying to do at the Boston Public Health Commission. I think it's an important addition to our timeline. Okay, so I said I was going to talk about data. So let's think about the data in Boston. Life expectancy, as we all know, probably life expectancy and infant mortality rate. Those are the two measures that we consider when we're really trying to think about the health and well-being of any geographic area, whether it be a city, a state, a country. you look at those two. And it says a lot about how much you value health and well-being. It just does, right? So life expectancy in Boston has been challenging. Overall, life expectancy is great. I think Massachusetts is number 2 now, right under Hawaii. But when you zoom in, and I'm going to show you what we zoomed in on most recently, but when they zoomed in, and this data actually came out in 2012, what they found is that there was a 33-year life expectancy difference between Roxbury, the picture that I showed you previously, and the Back Bay. In Back Bay, life expectancy 92 years, Roxbury 59. A life expectancy of 59 at this time when this came out in 2012 was the same as life expectancy in areas in sub-Saharan Africa. These two areas, 2.3 miles away from each other, but worlds apart. Interestingly, I had heard these data as an academic, and I said to myself when I took this job, this report was from 2012. These data came from 2003 to 2007. So that's 15 to 20 years ago at the time. We have got to have made some change. Something has to have happened by now that changed this number. We can't keep repeating the same thing. I want to know if something has gotten better. So after dealing with COVID-19 and working on that, I said, let's focus here and let's figure this out, okay? So what we did is we analyzed, interrogated our data, and I'm going to show you what we've been thinking about here. So this is life expectancy in Boston 2017 to 2021, average 80.2 years. Now that's good. That's top tier in the US. That's great. Okay, so if you stop there, you say, oh, we're doing great as a city, woohoo, and you move on, right? But then you look at the neighborhoods. Okay, our neighborhoods are primarily defined by our zip codes. Sometimes you have more than one zip code in one neighborhood. And what you see here, you have a neighborhood called Mattapan. Now, that neighborhood is primarily, disproportionately, I would say, in terms of the rest of the population. We have a lot of non-US born individuals, particularly from Haiti, who are living in Mattapan. Average life expectancy in Mattapan during that time period, 77.3. Now, if you look at the bottom, Back Bay, Beacon Hill, downtown, that's what I've already told you. Average life expectancy, 82.8. So if you compare those two neighborhoods, really, you're just talking about a 6-year difference. So again, you might say to yourself, well, that's not too bad. Let's leave it there. We don't need to go any further. That's not bad. And that's how people had been thinking about it since that first data came up, okay? But I said, we have to go back and we have to really zoom in. Let's go back to that census tract in Back Bay and that census tract in Roxbury. And let's see exactly what's going on, and let's compare it to what we knew of from that report in 2012. And so a census tract in Back Bay, again, 92 years, so very little had changed in Back Bay, good for Back Bay. Median income, $141,000, 91% of people have college degrees, and largely white, 82% white. Okay, so let's go back to Roxbury. So zooming in, this is the census tract with the lowest life expectancy in the city of Boston. And it's not exactly that same census tract, but it's close to that census tract that I talked about before. So now lowest life expectancy in Boston, 69 years, 70% lower median income. So $41,000 per year. College degrees, only 44%. And now we have a much more diverse population, which is primarily Black and Latinx. So now instead of a 33-year difference, now there's a 23-year difference. Now, I literally went on television about this and people were like, so that's good. Things have gotten better. I said, wait a minute, whoa. Let's think about data for a moment, okay? Let's think about why something might have happened here. So that's where you start to interrogate the data and you say to yourself, has there been a demographic shift? Has there been gentrification in this area? And the reality is that there has, and it's likely that most of this change has actually been due to that, though I have to say there has been some improvement over time. We're developing a full report, and this will be, available towards the end of this year, but the point is that we still have a very stark gap in life expectancy between this area, this census tract in Back Bay, and this one in Roxbury. Okay, so let's zoom out again. So from the census tract, let's zoom out. Let's look at the entire city of Boston. Now, obviously, all across the country, there were significant changes in life expectancy due to COVID-19. And Boston's no different. So as a city, we lost about 2 years of life expectancy. And there were differences in how many years of life expectancy were lost by race and ethnicity. Black individuals lost the most at 3.4, very close behind Latinx individuals at 3.1. The question now is, have those life years been regained? So let's see. Good news, and here I was on television again, good news, the life years have been regained for the city of Boston as a whole, and for Asian individuals and for white individuals. But not so much for Black and Latinx individuals. And for the most part, our actual gaps in terms of racial differences in life expectancy have actually widened from pre-COVID to now. So this is obviously very concerning. And we want to figure out, obviously, why and do something about it. So if you look at trends in average life expectancy in Boston, and this is saying similar data, but I'm showing you this as I think it's important to tell the rest of the story. You see the lowest line, the blue line, is Black individuals. So 7.5 years, that's average life expectancy between 2021 and 2023. Compare that to white individuals, 82.7, and certainly compare it to Asian individuals, 87.7. And you see there's a clear gap there. So when you see that kind of gap, what you want to do is you want to decompose that gap. You want to figure out what's causing that gap. Who is most impacted? Who is most involved in that gap? And I think it's very interesting when you do that decomposition and you see that the life expectancy gap is 6.45 years, and you see who by age is really comprising most of that gap. It's young people. It's young Black people under 40 years of age are comprising that gap. Now, when you think to yourself, okay, well, that's age, but what is it that they're actually dying from? So I know this is really small, the letters are really small, but what's happening here is basically another decomposition, trying to see which one of these causes of death are comprising this gap, this Black-white gap in life expectancy. Number one is unintentional overdose. Number two, cancer. And most of these are preventable cancers. And number three, heart disease. So these are the leading causes of the life expectancy gap between Black and white residents in Boston. Not so surprising, but I think this issue of unintentional overdose is particularly striking, and we'll come back to that. So then, when you look at this from the standpoint of premature mortality, because that's just another way to look at this, who is it who's dying young? Who is it who's dying below the age of 65? Look at these data and look at these lines. So what you see here is that premature mortality has actually decreased for every single group if you look between the years 2016 or compare 2016 to 2023, except for Black individuals, where premature mortality has actually increased 36.5%. So that's obviously problematic. And again, you say to yourself, well, what is it that these younger people are dying from? What is it that's causing premature mortality? The top leading causes, again, unintentional drug overdose, cancers, most of which are preventable, and heart disease. Okay, so then what do you do? Well, we'll come to what we're going to do about it. But let's go back to infant mortality rate, because remember, I said life expectancy is one way that we look at health and wellness in a society. Infant mortality rate is another important measure. Now, Boston infant mortality has gone down. I mean, that's great. This is a great curve to look at. It's great that it's gone down. But the question is there a disparity? Is there a difference in who's dying, who actually has a high infant mortality rate? Interestingly, this article was published in 1985. And it's basically looking at data from 1972 to 1979. And what it found is that there is a racial difference in neonatal mortality, so infant mortality, of about 6.9 deaths per 1,000 live births. Now, this was data, again, 52 years ago and published in 1985. So you say, okay, well, things must have gotten better since then. There must be a smaller gap. Something must have changed. Well, let me show you the most recent data. So this is our most recent data. And if you look at infant mortality, Black versus white infants, it's actually 3 times higher. And it's not, the gap is actually not so different. It's 6.5 versus the 6.9 that I just mentioned before. So 3 times higher infant mortality for Black infants versus white infants. Now we're seeing this across the country. This is not unique to Boston. I want to emphasize that. But it's striking the persistence and the pervasiveness of these data over time. And you see that with low birth weight, so 2.2 times higher. And we see that with preterm births, 2 times higher. We know what's causing the proximal causes of infant mortality. We know what's causing it in the immediate causes, but it's the bigger picture that we need to focus in on. Okay, so let's get to the why, because that's where we're talking about action, and that's why I'm here, and this lecture is honoring Dr. Berkman, because we're really talking about what is it that we know, what is it we don't know, and what is it that we should do about this. So Boston is resource rich. We've got 12 hospitals, 27 community health centers, 57 primary care practices, 13 urgent care centers, 115 pharmacies, all for a population less than 700,000. That's half the size of the Bronx. And we're 96% insured. We are a resource rich city. Okay, all these lines, these are all T lines. These are all MBTA bus lines. There's been a lot of work that's going on to improve access to healthcare. So is access the problem? Is healthcare the problem? Well, I mean, obviously I'm at a school of public health and the answer is no, but let's talk about it. So this article came out in the Boston Globe in 2017. And what it did was it basically said that, yes, the problem is what's happening within our healthcare system. It's what's happening inside the walls of hospitals and clinics. It talked about mistrust. It talked about language barriers. It talked about the fact that there weren't enough Black doctors. It talked about all things that we know are problematic, all things that I believe are incredibly important. But what I would say in my response to this is that that's not probably even half the problem. And I'll show you actually the models that show that that's not even half the problems. Health inequity doesn't begin or end within healthcare institutions. That is not the crux of the problem. And the other important point I think that it's good to make is that there have been a lot of changes within our healthcare institutions, enormous initiatives, millions, multi-millions amount of dollars, Unite Against Racism, all sorts of initiatives to address these issues, a lot of which came about because of COVID-19, but even before then. So there's been a lot of work within healthcare, less work outside of healthcare. So here's the county health rankings model. I think we all are aware of this in public health, this idea that the reality isn't that clinical care is really what's driving the health disparities. What is really driving this problem, what is most associated with low life expectancy, what is most associated with the persistence and pervasiveness of the data that I showed you, we're really talking about upstream issues. We're talking about social and economic factors. We're talking about our physical environment. That is where we need to create change. The problem is that most of our work has actually focused downstream. Now, this is a figure. It was published by a good friend of mine, John Auerbach, who used to be the Commissioner of Public Health for the city of Boston. And it's basically just giving you a sense of where we intervene. So downstream, obviously, healthcare, address individual healthcare needs. A lot of work in Boston has gone towards healthcare. More work, most recently, has gone towards addressing individual social needs. So that means giving people, access to food, giving people on an individual level a housing case manager, individual needs. But where the real problems are, and probably the reason that we haven't fixed the problem, is that it's upstream. It's about really improving community conditions. It's about addressing structural racism. It is about a whole of society. It says whole of government there. This should really be a whole of society approach to addressing inequity. That's what we don't really have, no matter how much we say it, no matter how much we know it, even though we're all here in public health and at a school of public health. That's where the real problem is, and that's where the intentional effort should be. But it's also most difficult for it to be there. So let's talk a little bit about Boston and why it's so difficult to make these changes. So here's some history. I like history. I like looking at pictures and sort of seeing where we were and where we should be, or at least envisioning where we should be. And so Boston, like other major cities across the US, has a long history of structural racism. This is the redlining map from 1938 from HUD. I mean, it's, this is, you probably have seen this before. I mean, the reality is that there are lines that people don't cross, didn't cross then, and in some ways still don't always cross now, at least not cross to really interact with people, to be quite honest with you. And what you're seeing is all of our upstream factors. You're seeing poor housing. You're seeing challenges in our school system. You're seeing all of the challenges with economic immobility and poverty. And then, I don't know how many of you all have seen this picture of the gentleman who looks like he's going to impale the other gentleman in the picture. This is actually a Pulitzer Prize winning photo that is from I believe it's 1976. And it was during, when you think about busing in Boston, there were busing riots, there was a lot of turbulence, there was a lot of trauma, there were a lot of protests, and this made a lot of news just because of the drama of it. But the reality is that it was this dramatic, and it actually still should be seen as this dramatic when you think about how wide the gaps are and how many people are dying unnecessarily and how many people are dying at young ages unnecessarily because of the structural violence and the structural racism. It's interesting though, because in public health, we know all this. And quite honestly, there have been programs to address all of this, not necessarily successful programs. Some of you may have heard of the Model City Initiative. How many of you have heard of the Model City Initiative? Okay. There are those of you who have been around who know about model cities. So this program was started by President Lyndon Johnson. So started in, say, 1967. The idea was to fund cities across the US to tackle these very issues in a way that would be sustainable, these issues in a way that would actually change quality of life, that would actually improve life expectancy, that would create new centers of urban health, new places where people would live, they would thrive. And so it was a great idea. And this was actually, these pictures are from the first pamphlet from Boston's model city. There was a lot of excitement about this. The problem, as you read through the literature, and I've read through a lot of the history here, is that there wasn't enough money. There was 147 places, cities across the US. There wasn't enough money. There really wasn't enough civic participation. This wasn't about shifting power to communities. It was actually about control. Because if you think about the late 60s, you're thinking about uprisings, you're thinking about protests. It was about controlling these cities, not making them thrive, not making them grow, not making them work better for their citizens. And eventually, when Richard Nixon became president, this whole idea was thrown aside. Not surprisingly, it was disbanded, and it went to community block grants, which is a whole nother worthy of discussion. But I mention this to say that this is not like we don't know the solution. We don't know what's wrong. And we knew that this probably wasn't going to succeed as it evolved, as we watched it evolve in these cities, as we saw participants from the communities not really leading, not really participating, as we saw money trickling in or not trickling in, as we saw police enforcement getting very much so involved, as we saw programs being established and not systems being changed. I think that was kind of obvious. So the question for me is, and this is why, I stay up at night thinking about this, so what do we do differently? Since we know the problems and we seemingly can't wrap our brain around how to fix it, or maybe there's not a will to fix it, what do we do? Well, what I would say is that there are efforts and there are things that we're trying to do differently. So when racism was declared a public health crisis in 2020 by Mayor Walsh, so the former mayor, he joined maybe 200 other jurisdictions who said racism is a public health crisis. And the reason that this happened was because we didn't deal with the issue that we knew how to deal with previously. That's how things happen. If you don't deal with them, they then evolve and they smolder and they grow. And then you're at a period of time where there are uprisings, where there are more protests, where people are murdered. And so now racism is a public health crisis in Boston. And a lot of people snickered at this. They said, racism is a public health crisis? Yeah, okay, so what does that mean, really? I mean, what is that really telling us? And not just in Boston, but across the US, what was stated is that these declarations are often symbolic, and APHA, the American Public Health Association, said this, but lots of other organizations said this. But what actually has impact and creates change is actually turning these symbolic gestures into action. And that's the key. That's what we need to do. We're very lucky in Boston in that, unlike other cities where racism was declared a public health crisis, what happened in Boston is that we actually got money. They actually took money from the police budget and gave it to the Department of Public Health, and we actually put it out. Yeah, it's a big deal. That didn't happen in most places. And it's actually part of our city appropriation. So these are the things that give me hope that things can change. Okay, so how have we tried to change a symbolic gesture into action? Okay, so this is Live Long and Well, and I'll tell you about what it's comprised of. It's our population health agenda in Boston. And what I look at it as, it's really our city's commitment to advancing health equity. There really hadn't been a commitment. Okay, so there was a declaration and there was some money, some of which I think was used a little questionably, but there wasn't a commitment to actually doing things differently. So that is what we've put forth. So we're going back to that data, that premature mortality data, cardiometabolic disease, preventable cancers, overdose mortality. I talked about infant mortality, and also maternal health is a problem, as we all know nationally. And we're going to say we are going to address premature mortality in these areas, and we're going to do it in a way that's sustainable. We're going to do it in a way that's robust. Now, again, I think I said at the beginning that I'm not telling a story of success yet. Give me time. This is a work in progress. But what we think we're trying to do is we're trying to have a whole of society approach. So community, number one at the top, certainly public health, other public government entities, and that's education, housing, transportation, parks and recreation, everybody. Our hospitals and community centers, all on board. Our private funders, not always on board to an extent. And then certainly advocates, because we need people to make us accountable. We need people to keep pushing us. We need people to call us on things that don't make sense and when money is not going in the right direction. All of these things are important if we really truly want to lower premature mortality in Boston and advance health equity. And a lot of this is about applying lessons learned from COVID-19. Because if it's not a all hands on deck approach, if it's not a whole society approach, we will all fail. And I think that's a message that, for a variety of different reasons, hasn't gone beyond these pandemics. So hasn't gone beyond COVID-19. So people realize that when there is an inequity, when you have an infant mortality rate that is 3 times higher in one population than another, we have all failed. It's all of our problem. So what are our essential inputs? So I spent a lot of time talking about data because we have to lead with data. We have to not only collect our data, not only analyze it, we have to interrogate it. We have to really understand what our data is telling us. We have to shift decision-making power from institutions to communities. We cannot continue this having a community advisory board, a community action network, so on and so forth. They actually have to have decision-making power. We have to establish some shared goals. It means we all have to be on board and say we are all going to do this together. And this is our target. This is what we're all driving towards. We have to invest collaboratively. I'm emphasizing this point about investing collaboratively because we have in Boston, as I said, major healthcare institutions, and they bring in a lot of money and they invest. There's no doubt about it. They invest in our communities. They do the work of anchor institutions. Until recently, they had not been doing it collaboratively. There's a drop of 1 million here, a drop of 5 million here, but working together with shared goals, we could do so much more and it could be so much more sustainable. I think that our efforts need to be place-based. We need to be accountable. Things need to be sustainable. And I'm going to emphasize this again. We have to think about system change and stop with the programs, because we do a lot of programs. That's nice. I think programs are good. They may help an individual. They may help a household. They may help 10, 15 individuals, a household. You have to change a system. Otherwise, it's really not going to shift the dynamics that we've seen. Okay, so let me talk about substance use disorder, because I think that is where there are many, many challenges. And I think it's important for us to really understand exactly what and where we're going here. So in Massachusetts, from 2022 to 2023, our overdose deaths decreased by 10%. That's Massachusetts as a whole. At the same time, in Boston, overdoses increased 12%. And most of that increase was amongst Black individuals. And as we looked at the data, we said to ourselves, what exactly is going on here? What's different here? And so I wrote about it in this op-ed. And the proximal reason is because there's significant contamination of our cocaine drug supply with fentanyl. And lack of awareness that that's happening, lack of awareness that naloxone is something that you need if you are using cocaine, and stigma, a lot of stigma that's driving what was happening amongst Black individuals. I say what was happening because we have made some changes and we've gotten word out there, which is what I'm going to talk about. But it's really understanding our data and figuring out why overdoses, particularly amongst Black people, Black young people, are leading to lower life expectancy and increased premature mortality. So interestingly, Boston has this very long history of being a forerunner, of being an innovator in regards to substance use disorder. Back in the early 80s, late 80s, AIDS Action Committee was operating an illegal needle exchange. We had ordinances passed by our city council. We started AHOPE, which is our treatment overdose prevention education program. A lot of this we were doing in synergy with New York City, but I have to say that there were a lot of things happening underground, particularly as it focused in on HIV in Boston that I think that we are all very, very proud of. But one of the things that had not happened is we had not really looked at this as a problem that must start upstream. It must start with our housing policy, because while we had many people who using had substance use disorder, getting access to clean needles, they were still on the street. And we had a large encampment in Boston for a long period of time. And this is something we had to change, and we had to change the system of housing in Boston. So we developed and adopted a housing first policy. And so what that means is that before anything else, it doesn't matter if you're using, doesn't matter if you have mental health disorders, doesn't matter what it is, you will have a roof on your head, over your head in Boston. And I think that's a critical policy shift. And it was something that really got to the upstream as opposed to thinking about just the downstream. So that's Mass and Cass, the picture at the top. Again, it doesn't look like this anymore. We now have a tent ordinance, and we can argue about whether or not people should tent or not tent. But it was an area that was extremely, extremely dangerous in Boston, where there were outbreaks of a variety of different infectious diseases. We had a lot of gang activity. When we cleared the tents, there were all sorts of weapons, some of which I've never seen the likes of, all over that the police were collecting. So this had to be dismantled, and we knew it needed to be dismantled. So what we did was we collectively and collaboratively invested across many different funding lines, and we created 6 low threshold spaces for people to be, to live, to essentially be moved to from the encampment while there, get medical care, get psychiatric care, get access to medication for opioid use disorder while they can continue to be using. And all of these places, I should say most of these places, have safe use sites inside. And that's something that doesn't come up in the media. We don't have the typical or the standard or the gold standard overdose prevention sites like you have here in New York City, but we have safe use in our low threshold housing spaces. So then the question becomes, what about racial equity? Because what I told you was that really the problem here in terms of increased substance use disorder, increased overdose mortality is really amongst Black individuals. So we have to make sure that everything we do is actually equitable. We have to make sure if we're putting a policy in place that it's not unintentionally harming people in a way that we would not want it to. So we have a grant from OMH, and Congresswoman Presley was a big supporter of that, of us getting that particular source of money. And essentially what we've done is we've looked at our data and we've made sure that all people have access. So there's no racial inequity in access to housing or in outcomes. And this has been a big investment for a city the size of Boston. So $10 million investment over the course of 2 years. Now, can we keep that up? I don't know. I'm hoping that we can keep it up because it has been a major success. There has been pushback from our states not wanting to fund some aspects of it. Our hospitals have contributed. Our police have been very involved, all of which, from my standpoint, really indicates significant change in Boston when you have all of these different players who are coming to the table with one goal. We also have opioid settlement dollars. So we have about $38 million that in most cities are getting their opioid settlement dollars. I think that what I've learned in talking to some of my colleagues across the country about opioid settlement dollars is that in some cities, it's not even being used for people who are living with substance use disorder. It's being used to fill potholes. That's verbatim from some of my colleagues. It's being used to, in some cases, refurbish schools. It's being used for other things. And I understand why that is the case, because money has been shifted from those line items into substance use disorder because it has really been a challenge for many cities. But we are determined not to make that happen in Boston. And we're determined that whatever it's used for, it's going to be dictated by people who are living with substance use disorder, who are working in the field. So we had a very large community engagement effort in the summer of 2023, lots of listening sessions, surveys. More than 2,000 Boston residents responded and said, okay, what is it that we want this money to be used for? And what they said, number one, housing. And we need to prioritize those populations who are struggling the most. And we know that that is by race and ethnicity, Black and Latinx individuals. Give the money to the community-based organizations. They know how to do the work. They can get naloxone into people's hands. They can get out on the street and talk to people and actually find out if people want to go to detox. They can actually navigate people there. Think about overdose prevention in a really robust way. Naloxone should be in every pocket for people who are working in businesses, who are traversing through areas where we know people are on the street, where there's a risk for overdose. That is what should happen. And then also there are many, many families that are grieving. There are many, many families who've lost loved ones. So we created a fund for them to pay for therapy, funeral expenses, childcare, so on and so forth. But the point here is that these are the desires of the people. This is the decision-making power that comes from the people. It's not coming from, the mayor's office. It's not coming from sitting in a city council, hearing or whatever. It's really coming from the people. And I think that's what makes this different. And then we also have CDC funds. So bringing all of our funding together, really thinking about how can we increase capacity to prevent and respond to overdoses. And our goal here is to decrease overdoses citywide by 50%. And what I can share with you is that we compared our data from January through April for this year compared to last year, and we have decreased overdoses 33%. So we're not there. 33% citywide. Amongst Black individuals, it's been about a 50% decrease, and amongst Latinx, it's been about 55% decrease. So we have made changes. Now, there may be many reasons for all those changes, but one cannot discount the impact of this type of work, and I really do think it's important. This is public health in action. Okay, let me turn to live long and well, and please tell me if I'm going over time. I'm okay? Okay, so let's talk about another aspect of live long and well, because like I said, we had overdose mortality, we had heart disease, we had cancer, and we had infant mortality. I can't talk about all of them, but I do want to say a few words here about heart disease. So this is a new initiative, and it was really something that has taken about a year for us to pull together. This idea that can we target funding from a private foundation towards upstream factors that will eventually decrease risk of heart disease, as well as poor outcomes from heart disease, or particularly cardiometabolic disease. Can we develop interventions that are upstream, midstream, and downstream, so multi-level interventions? Can we be impactful? Can we bring in the private funders that I mentioned originally that need to be brought into this type of work? And so we have been somewhat successful, but we're not quite there yet. So in our discussions, what we said was that if you look at all the upstream factors and look at the efforts that have gone around and had some impact around Boston, there's been a lot of effort regarding housing. There's been a lot of effort around education. Where there's been less effort is really about economic mobility. There's been less effort looking at health and wealth and the interaction between the two that we know is there. There's been less effort and less potentially maybe less desire to put money there, because the question is, can we sustain that impact over time? Many of you have probably heard about these guaranteed income pilots, these cash transfer pilots that people are doing across the country, where money, $500, $800, even some $1,000 per month, are given to certain members of the community with no strings attached. Now, I have to say that when we posed this to Mayor Wu, her first question was, how are we going to sustain that beyond the pilots? I mean, why would we do that? It doesn't make any sense. And she's absolutely right. So then the question becomes, what could we do with a pot of money from a funder? So we're still in some discussions about that. We did establish a reparations task force. So the question is, do we need to think about this as reparative justice? Is that a better way to think about it? Would that narrow the amount of people who actually need to be funded? Is that going to narrow our problem in some way? Well, not really sure. But what we've done here is that we've brought a lot of people to the table. So we've brought our Office of Economic Advancement, our Workforce Development Department, Housing, others together to think about this problem. And as I mentioned, we've also brought community to the table. So one of our partners in this work is the Boston Community Health Collaborative. That's really about a lot of different entities, but the focal point of this is that it's community residents who are actually getting together and saying what their concerns are and what they want to do with this money. Again, I'm emphasizing that community has to lead, that we must shift power into communities. And so with their help, they put together a community health improvement plan, and the number one thing on their list was economic mobility and inclusion. So we know we're at least on the right track. We know we selected the right issue, the right thing that we need to tackle. But the question now is, how do we do that? So what we have is a $10 million investment, and that's from Atrius Health Equity Foundation. And the Atrius Health Equity Foundation has about a $150 million endowment. I don't know why they couldn't give us more than 10 million, but that's okay. We work with what we have, and we're hoping that it will be catalytic, meaning that we'll hope that other people will see the benefit of this work once we move it forward a little bit further, and we'll get more money. So the idea here is that the focus will be on promoting economic mobility in a place-based way. So in areas like that census tract in Roxbury, like census tracts in Dorchester and Mattapan, we'll be partnering with community health centers, hoping that we can, move economic mobility forward in such a way that does have an impact on outcomes, particularly cardiometabolic outcomes. So we'll see where this goes. But again, I think this is something that important in that it brings a lot of people together. It's a multi-sector partnership, and it's the way to think when you're thinking about systems change. How do you change the way things are operating? All right, so let me talk about infant mortality. And this is, I think, the last example that I want to give this afternoon. So you saw the infant mortality data. It's striking, it's stark, it's problematic. And you probably said to yourself, so what are they doing about this? What have they been doing about this over time? Well, Boston's been doing a lot about this. There are multiple programs, multiple initiatives. There's Healthy Baby, Healthy Child. This is a 33-year-long program that's federally funded that provides a comprehensive set of services all across the city of Boston. Most of the women are Black or Latinx. Nursing, home visits, advocacy, social work, mental health. All of this is offered on an individual basis. It's offered in households. Okay, so I'm telling you what's wrong here. And I shouldn't say that it's wrong, but it needs the bigger context. Okay, it's been successful on an individual level. It's been successful in households. There are many women who come back and say, wow, I'm glad that you did this for us. You did it for a time limited period. You did it until my child was age 5. Now I'm out there and I'm struggling. My community necessarily hasn't changed, but I appreciate this program. Okay, so that's good. So what we've been trying to do is kind of move beyond that. But I have to say, it's been a struggle, because there is this sense that if we do more, if we scale up our work further, if we do more home visits, if we have doulas and have everybody have access to doulas, if we involve more community members in like a community advisory board, maybe this will change things over time. Luckily, we were able to get some legislation passed, and that increases access to midwifery care, all of which, again, is within the walls of a healthcare system or within the walls of a birthing center. Again, we're talking about what happens on a one-on-one basis, on a household basis. It's downstream. A lot of it now is midstream, but it's not upstream. It's not changing things within an actual community. And our goal, yes, we would love to lower Black infant mortality in Boston 20% in 5 years. I don't know that we're going to get there with this type of program. And this is something we're actually writing about now, trying to figure out how to change this dynamic, but it's hard because these are the easier things to do, actually. This was a lot of work, but these are the easier things to do than it is to really change communities. So the work that we've done, the things that I've shown you, even though we're not at the point where I have final outcomes where I can tell big success stories, it has been picked up statewide. And our Secretary for Health and Human Services is a champion of our work, and she's moving this to a statewide program. So their version of Live Long and Well is not just in Boston. It's now statewide. It's Advancing Health Equity in Massachusetts, or AHEM. They've decided to focus in on maternal and perinatal work and infant mortality. As I showed you, that stark data is true across the state. They've also decided to work on cardiometabolic health, again, one of the main causes of premature mortality. So we're proud of the fact that our state has picked this up and wants to do more in line with what we're doing in Boston and really be forward thinking and reimagining what health can look like in a city, in a state. So we're proud of this. So they actually picked 10 locations around Massachusetts, all of whom have challenges in health and equity, and they are looking for funding now so they can do what we've done. They're looking for ways to bring together diverse communities like we have with the Atrius Health Equity Foundation example, bringing together people, stakeholders, so that they can actually make the decisions and decide the direction of this work. So in sum and in conclusion, what I wanted to share with you is that what we're trying to do is a call to action. We're trying to bring people to the table to see that the inequities that have persisted don't need to exist. We can actually create change, and we actually know how to do it. It takes a lot more than what we've been doing. It takes a real intentional, concerted, collaborative, de-siloed effort. But I do see signs of hope. And I see it throughout Boston. I'm seeing it, as I said, in Massachusetts. And quite honestly, I've been working with other commissioners across the country, and I'm seeing it in other places too. We're all thinking along the same lines. What can local public health do? What can cities do? So if you are at APHA coming up at the end of the month, 5 cities. There are 5 of us who will be talking about our efforts to do exactly what I just shared with you. I think this will be a good session. Obviously, it's way too early in the morning, but it'll be a good session if you are there to hear about this call to action, to hear about how we're trying to move things forward on a local level, things that will really change the life expectancy gaps, things that will really lower premature mortality, and that will really sustainably advance health equity. So I want to say thank you. Thank you so much for having me. I also want to acknowledge my team. Without a village, slide sets don't get made. You know? I have a Center for Public Health Science Innovation, which we started, and great epidemiologists. We have a great communications team, and really all of our staff are on board and excited and want to make this happen. So thank you all very much.
Thank you so very much. Excellent talk, excellent information, very motivating. I'm now going to ask for those who have questions that are in the live audience to come to the mic. But while that's happening, there is a question online that kind of follows up on your point of reparations. And they asked, can you give a little bit more of your thoughts on reparations as a public health strategy, in addition to being a debt due?
So unfortunately, reparations are controversial. I don't see them as controversial. I see this as a strategy like any other strategy, a way that we know will decrease disparities. We know it will. We know that giving people money, if that is the target or the intervention that you use for reparations, because reparations can be a broad set of ideologies, a broad set of interventions. We know that it helps. We know it from all the pilots. We know it from, you know, all the data that's out there. So I don't see it as controversial. And I do think that it's a public health strategy. I think that we have to get past some of the philosophical divide. I think we have to get past some of the animosity, the feeling as though you're being blamed, the feeling as though their blame is being placed. I don't think that's it at all. I think it's a strategy. And I think all strategies need to be on the table.
Yes, thank you so much. Wonderful talk, and so much at the core of Alan Berkman. So I'm so happy you're here to have the opportunity to recognize him and remember him. I had a question. I think I was just curious. You spent so much of your career internationally as well as domestically. And I'm just curious, like, I always feel like there are lessons learned from the global to the local, local to the global. I'm just curious, like in your experience, are there things that from your international experience where there are different kinds of disparities, but a lot of disparities, some lessons that you think are relevant to us here in the United States that we can think about implementing?
No,
Thank you.
I hear you, and I think that that's a great question. I have spent a lot of my career with my foot in both worlds, if you will, but we're, you know, obviously one world. I think that what I saw, what I learned internationally is that it was just secondhand to know that you have to get into a community, that you have to talk to people, that communities need to be, whatever the village is, go to the village. Don't make a decision about the village sitting in the major city. Everybody knows this and everybody does it. It's part of the plan, you know, and for a variety of reasons. And we could get into the history here. We talk a lot about that, but we don't really do it here in the US. We make a whole lot of decisions independent of the people who are actually living the experience. There are people who will drive through Boston, and those of you who know Boston well, that you drive down Mass Ave and really never go to your left, which is towards Roxbury. It's into those areas that I showed you pictures of, where people are struggling, where there are housing developments, where there's trash, where there are a lot of things that are just wrong, and just ignore it. And even those people who are doing the work in academia will not have been there, will not know anything about it. And I think that's the biggest lesson that just seems obvious, but for whatever reason, it hasn't transferred very well. And I think that's kind of a shame.
Yeah, hi, thanks. That was great. Really, you know, makes me think about Alan, you know. The points about housing being so fundamental, you know, is one that kind of struck me, because here in New York, you know, this is where the idea of housing first originated, but it's been like 30, 40 years, and we have 3 times more people who are homeless than we did then, you know, which we never imagined would happen. And yet we've had so many progressive health commissioners. We've had progressive people who are leading the Department of Homeless Services, but it's never translated into any actual, there is no housing first program in New York. And it's simply, no mayor has been willing to implement it, you know, or even to take it on as an objective. And it's, we've been advocating for it forever, all kinds of groups. So how do you meet that? I don't know how to meet that challenge. You know, it's very difficult after, it's got to be met, but you know, it's the first thing. But so in Boston, in many countries, it's being done, even in Brazil, but not in most cities in the US, and not in New York, where, you know. So I'm not asking us of desperation. I'm asking you, how could you do it in Boston, you know, in a sense, because we haven't been able to.
So housing is a major challenge, as you expressed. And I think I've been just as frustrated as our chief of housing, as our mayor is, about what we should be doing. The housing first policy that I described was a part of a much bigger puzzle that hasn't been solved, and I don't want to make it look like anything other than that.
Right.
Boston struggles just like New York City does. But I would say that it's a struggle on a different scale. If you're talking about 680,000 people and within a less than 50 square mile radius, there are different housing challenges. There's no place to build, right? And there are other things that are going on. But what I can say is that a lot of our work in public health, in a sense, it really has been piecemeal. It's like, let's get our foot in the door. Let's make sure that this group of people has housing. We're also working on trying to improve the family, housing, the family shelter system. Very problematic. I didn't tell you this, but so our public health department actually runs the largest shelters in New England. So we're struggling. I'm telling you, we're struggling. We're busting at the seams. People are laying on the floor. There are all sorts of things that are happening in that system. So it's a problem everywhere. But I do feel that for that population, getting them out of that encampment where, like I said, there were some major things happening, human trafficking, so on and so forth, that was our attempt at a housing first policy that was related to substance use disorder, mental health, mental illness. But it's a much bigger issue.
Okay, thank
And I'm frustrated like you are.
Thank you.
After you. I was wondering whether in the communities that you've been doing the groups with, the whole issue about the interface in the communities with the jail, prison, and all that system, it's certainly a structural issue of mass incarceration. And I don't know how much it's coming up about the constant
Yes.
in and out and the impact for all these issues.
Absolutely. We do have an office for returning citizens. We work very specifically with people who are coming back into communities. The challenge that we face, and most jurisdictions face, is that a lot of the folks who are coming out of our jails and our prisons are going on the street, and some of them are overdosing. They're coming out of prison and that's what's happening to them. And the question is, can we really provide the right supports before they're released? And so we're actually working with Boston Medical Center. We're working with our Suffolk County Jail, and we're meeting people before they come out, because obviously that's a very vulnerable period. And it's also a lot of stigma obviously involved there. So then you have to figure out, so where are people going to go when they come out? And so that is a very important population, and it is critical to our work.
Yes.
And I know that was a passion of Dr. Berkman, so I appreciate the question.
Yes, hi. Thanks so much, Daniela Roccarina from New York. Thank you for your insight and your presentation. My question relates a little bit to Wafa's question about international global perspectives, but at home, I struggle with the division of infant mortality from maternal mortality for a number of reasons, which I'm sure you know. And so my question to you is, how do we not do that from a policy perspective? We lived through it for HIV/AIDS, right? Where we focused first on neonatal screening for HIV in the absence of looking at the woman's health. And so how do we unify that in a way that our policies support families, support women? And of course, if you have a healthy woman, you're likely to have a healthy baby. So tell me from your perspective, both internationally, if there are differences in terms of our policies that have led to this dichotomy, and what you might propose as something that might unify those.
So let me start with the latter portion of your question. How do we unify them? I think that the program that I showed you, and again, I'm talking about program, not talking about policy yet. The intent there 30 years ago when it was started was to be unified, was to think about, perinatal health, was to think about the woman's health before she gets pregnant, and then follow them, up to 5 years. I don't know that that's really what ended up happening. And I think that there was a divide, a schism, as you said, and it tends to focus in on the child. And
I'm a pediatrician, by the way.
yes, I appreciate that. I appreciate that. It tends to be a divide as opposed to being a collaborative effort. And what that's left us with is a situation where we have poor maternal health outcomes. We have severe maternal morbidity within our state. I could have shown you, data, and it's been very problematic. And the legislation we've moved through is really focused in on midwifery support, doulas, doing fetal infant mortality review. So it's really not necessarily thinking about the health of the birthing individual and the bigger picture, the health of the community in which the birthing individual lives. So this is where we all need to be more comprehensive in how we're thinking about health. It just doesn't make sense how we're doing this piecemeal approach. I'd have to say, and I mean, I would go back to thinking internationally, thinking more comprehensively, thinking more holistically about what produces health within our communities. We cannot continue. We won't get anywhere if we continue along these lines. And even as we maybe tick away or help or do some advances in terms of maternal morbidity and maternal mortality, we're still going to look at these huge gaps unless we think bigger, unless we think broader, unless we make policies that actually move an agenda forward that's not just about the individual, whether that individual be the infant or that individual be the pregnant individual. You see what I'm saying? That's my point. And I think that's the hard part, though, is getting somebody at the table who doesn't necessarily want the immediate results. Because the immediate results is a healthy baby. That's not that. Well, I mean, that is part of it. It's like, okay, what actually gives us the healthy baby? What gives us the mother who didn't have a severe complication, who didn't bleed out, who didn't have a pulmonary embolism? Those are immediate results. We want bigger picture. We want age long. We want lifespan long health and wellness.
Let's keep working.
Thank you. That was an excellent presentation. I particularly appreciated the historical data perspective, et cetera. My question speaks to the call for collective action. You listed a number of things, and I think there are a number of directions one could go in there. So I wanted to dig deep on one that's important to me, that I'm focusing on. And the one aspect you talked about was accountability and sustainability. You talked about it from like a data, policy, et cetera standpoint. Can you speak more to what that may mean? Maybe within Boston, but since we live here in New York, maybe a more national example?
So what you're saying is, how can we be accountable
and sustainable
in the systems, in our systems
for health equity?
I think number one, we need to prioritize accountability and sustainability. I don't think that we do. What I was saying in my response to that question, we tend to, and I think this is whether you're here in Boston, here in New York, whatever state you're in federally, we're looking for, in some respects, quick answers. We're looking for answers that get votes. We're looking for answers that are politically pleasing. We're not necessarily, just like that Model Cities program, that lasted for about 5 or 6 years. Okay, it just wasn't going the right direction, got defunded. Who knows if they had put the right inputs in, had they kept investing, had they not had the challenges with policing and different aspects of that, had they continued to do that, what may have come out at the end of the day? Having civic participation, people leading, thinking about health, thinking about the broader context. Could we do that on a national level? My answer is yes. But it's not about the answer that you're going to get in 2 years. It's not about the answer you're going to get in 5 years. We're talking a decade, at least, of work. That's the kind of thing that I think is going to be important for how we think about inequity.
Thank you.
Let me ask one more here. And I want to say thank you, Commissioner, for just a great presentation. And I think there's so much for the students to learn. There's quite a bit for our faculty to learn here as well about action, and your experience is quite a model. Your life experience and then into the position you have now. So my question is a little bit more hyper local. So I appreciate the framing that Boston has done of racism as a public health crisis. insufficient housing is a public health crisis and on down the line. I'm wondering, that framing is coming from your office, which is wonderful. Many of the cities that I've had the opportunity to work with health commissioners and other leaders in those cities, one of the great pieces of advice I try to give is like, can you get the health commissioner and the police commissioner sit on the same panel and present together?
Yeah.
And come to term, come together and speaking out about things, because I mean, 35 of the 50 largest cities in the United States and all 50 of the largest 50, the police department is the #1 budget item in those cities, right? So it's an enormous budget relative to the public health budget. And when you compare that as well, perhaps the housing budget is not what the police budget is, but it's also quite large. And then you and I spoke a little bit about local medical resources. The local medical systems, whether they be public or private systems, are enormous relative to public health. So how does a commissioner like you really step out and make these sorts of inroads, but then bring these other folks, the other leadership in your municipality along?
So I think that's a great question. I think that's a challenge that we face across the country within large cities, but within smaller cities, within, rural areas too. I think the best example that I can give goes back to the way that we have addressed substance use disorder and unsheltered status in the city of Boston. So every week we sit down with the police commissioner, the police commissioner's chief of staff, a lieutenant, a superintendent. As public health, we sit down with some other folks from housing. We sit down with other folks from our parks and recreation, and we talk. And sometimes those conversations are very challenging. Okay, because philosophically, I'm saying that needle exchange is incredibly important if you don't want a Hep C outbreak, if you don't want a HIV outbreak, if you want to understand and meet people where they're at, we have to do that. And this has been going on for probably about 2 years, almost 3 actually at this point, that we've been having these conversations. And I have to say that multiple conversations, multiple sharings, me coming to the middle in some ways on some issues has allowed us to move forward, and I'm not saying we moved forward a lot. Hopefully I didn't relay it in that way. It really is that we've taken some important baby steps forward. We all agree that an encampment where we had outbreaks of infectious disease, where we have human trafficking, that was not going to work in our city. Therefore, we have to figure out a better way to do it. Therefore, we all have to agree that we're going to do outreach, and we actually do outreach together. There's a street outreach team from BPD, so from the Boston Police Department, and our street outreach team. They don't get along, and they don't always go together, but they're all doing outreach, and they're all saying the same things to try to get people into care, give them harm reduction, so on and so forth. But there's a lot of friction there. I mean, it's philosophical friction that everybody is dealing with, but it really has taken a lot of coming to the middle, for me, taking my infectious disease doctor advocate hat off sometimes and not being the revolutionary in the room, but instead being the mediator between different folks, because I have some firebrands in my team, who want nothing to do with the police at all. So, but the point is that we're still doing it. The meetings haven't been canceled yet. And there was a period of time in Boston when they would have been. So I think that is a step in the right direction.
Thank you.
And we have one final question from online, and then we'll head to the reception. There's an HIV wildfire brewing among adolescents in sub-Saharan Africa at this time. More adolescent girls are getting HIV than perhaps any other demographic. What do you think global and international health efforts are missing to end the global HIV pandemic for good? Hey, it wasn't my question.
Right. No. I mean, I think that's a huge question. And I'm not sure that I have the full answer. I think, if you want to just think globally about HIV and HIV transmission, particularly amongst women, we have other experts, Wafa, in the room who could talk about this extensively. I think that number one, we have to go to root cause and really root cause analysis. What is happening in the lives of young women? What opportunities are they getting or not getting? What are the relationship dynamics that are going on? And these are all things I think a lot of people have been thinking through and trying to work towards. So what are we missing? You know, quite honestly, I still don't think that we are putting enough effort into global HIV as we should. We're not putting enough effort into global health as we should. We know what's happening with COVID-19. We know what's happening with Mpox. We know what's happened in terms of access to care and access to treatment in other parts of the world. We know that women should be on PrEP and they're not, you know, both here in the US and overseas. And we're not doing enough, but there's also not enough intentional effort, putting it in the right places, involving the right people in the discussions. I think that there's been a lot of important effort. You know, I've gone to many International AIDS Society meetings where there have been the great people talking, great people thinking about ways to do things, but more of it needs to happen. And we really, again, need to think about root cause and how we change the lives of these young women. I mean, if you've been to sub-Saharan Africa, many cities where, you know, girls are not getting the education that they have, that they should have. They're not getting opportunities in terms of work. They're not being able to choose partners. They're choosing partners for the wrong reasons. I mean, there's so many different factors there. But really, it goes back to what I've said already a couple of times, that it's thinking about comprehensive, more holistic responses. It's not just thinking about the immediate. It's not just about PrEP, though PrEP is important. It really is thinking about the bigger picture. And I know that was a huge question. I probably only answered one iota of it, but.
No, thank you. I want us all to provide one final applause for an amazing
Thank you.
lecture.
Thank you.
I want to thank the Berkmans for being here, friends and family, and please partake in the reception outside. I know there's somebody been guarding it, so now you can go to it. Thank you so much.
Thank you.
Usually here on Wednesday.
Yeah, right.